Hello, my name is Ashley Luneau, and I am presenting on preventing postoperative surgical site infections through standardization of preoperative surgical skin preparation, a pilot study. My background is surgical site infections are currently the most acquired hospital-acquired infections, leading to death, longer hospital stays, higher costs of care, and readmission to surgery. Surgical site infections account for 20% of all hospital-acquired infections and 38% in surgical patients, leading to an increase in the length of hospital stay from 3.3 to 32.5 days, and patients are twice as likely to die, twice as likely to spend time in intensive care, and 5 times more likely to be readmitted after discharge. Anderson et al. State that surgical site infections occurring between 160,000 to 300,000 times per year in the U.S. are responsible for 20% of all hospital-acquired infections, attributing to longer hospital stays, death, and account for $3.5 billion to $10 billion annually in healthcare expenditures. Anderson et al. Further explained that of the surgical site infections, an enormous estimation of 60% of the infections were preventable. The CDC defines that more frequently, the date of an event for infection occurs within 30 or 90 days after surgery. Shockingly, UVMMC, the site that I work at, only had one deep sternal infection out of 240 cases in 2019, and one deep sternal and 3 superficial sternal infections out of 378 surgeries in 2018. However, the goal of healthcare is prevention, instilling agreement that no patient should suffer a sternal wound infection. My problem statement, surgical antisepsis performed by the nurse prepares patient's skin to decrease surgical site infections and the possibility of surgical wound infections. Surgeons at the project's institution have varying skin prep preferences, resulting in increased variation of care, potential adverse events, and unpredictable quality of care. The Northern New England Cardiovascular Disease Study Group concluded in their outcomes report that within the last 500 cases, the institution that the study is being performed at, 1.3% returned to the operating room for bleeding, and mean and median postoperative length of stay was 6.2 and 5 respectively. Comparable to other institutions within our network, the institution's mortality rate due to infection during admission, however, was far the highest. The use and standardization of a chosen agent increases compliance among antiseptic application in order to prevent postoperative infections. Using a standardized surgical prep for cardiovascular patients, the nurses performing the prep decrease the risk of postoperative infection by eliminating one possible source of variation. My purpose: the project aims to provide a cardiothoracic and vascular surgical nurses with evidence that a standardized agent to prep patients with prior to surgery is preferred to prevent surgical postoperative infections and enhance EBP into daily practice and hospital policy. An 18-item pre- and post-test will be conducted using the Johns Hopkins Evidence-Based Practice Implementation Scale by Melnick, measuring the decrease in wound infection in patients as related to antiseptic prep chosen. Additionally, the Lewin's change theory will be used to evaluate the nurse's success in rejecting previously used antiseptics and adherence to evidence-based practices in an effort to prevent postoperative surgical wound infections. My research question: what is the effect of a standardized preoperative skin preparation educational intervention on OR nurses' adherence to reduce cardiovascular postoperative surgical site infections? The null hypothesis is education of a standardized skin preparation will not reduce the incidence of postoperative surgical site infections, and the nurses will not adhere to the standardized protocol. The alternative hypothesis is education of a standardized skin preparation will reduce the incidence of postoperative surgical site infections, and nurses will adhere to a standardized protocol. My measurement tools: first, the retrospective chart review. I will use a demographic data worksheet to collect pre- and post-intervention chart information amongst vascular patients from June 2012 to 2015 and June of 2018 to June of 2020 for cardiac patients. Connecting with the cardiovascular offices, information that the researcher will be extracting and recording from the EMRs of patients will include such information like age, gender, surgery, surgeon, and the patient acquired, and if the patient required an infection postoperatively. The preoperative knowledge assessment questionnaire, consisting of 22 questions, will be used to measure the nurse's knowledge related to the application of surgical prep agents for cardiovascular patients. The pre-intervention questionnaire examines the surgical nurse's understanding of the manufacturer-recommended and standardized protocol for antiseptically preparing a patient for surgery. The question consists of 9 dichotomous questions and 13 multiple choice questions. It will provide baseline knowledge of the participants regarding preoperative surgical skin preparation, proper procedural steps in prepping a patient, dry times, and the process if contamination occurs, and key anatomical order of prepping. The pre-knowledge test will undergo face and content validity through the use of 5 expert surgical nurses. Reliability will be assessed through a test-retest manner in 10 OR nurses. The post-intervention adherence questionnaire will be completed by participants after each cardiovascular surgery is completed. This is a 22-question test that evaluates the adherence to the manufacturer's recommended process for surgical antisepsis process. The questionnaire consists of 12 dichotomous questions measuring adherence to skin preparation procedure and 10 open-ended questions that assess the recommended preparation process. The post-intervention adherence questionnaire will undergo face and content validity through the use of 5 expert surgical nurses. Reliability will be assessed through a test-retest manner in 10 OR nurses. Adherence will be measured with the Evidence-Based Practice Implementation Scale by Melnick. The EBPI scale was designed to identify the frequency of use of EBP behaviors. The 18 items model is on a 5-point frequency scale, asking how often in the past 8 weeks the RN has performed an EBP activity. This scale is especially applicable to the project, for it helps correlate if the nurse performed the EBP in relation to the educational session provided by the researcher related to the specific antiseptic surgical preparation, and it helps correlate if the nurse performed the EBP in relation to surgical preparation and the resulting or lack of surgical wound infection. This project will effectively measure how often the nurses engage in the use of an antiseptic solution, adhere to application protocol, share the knowledge with colleagues, and change their practice from previous products in direct correlation to understanding and supporting an EBP. Scoring nurses on a scale from 0 to 72, the EBPI scale lists of questions are linked to actual EBP in essential steps and components of measuring a performance, measuring whether evidence was used to change clinical practice, where higher levels reflect more frequent uses of EBP behaviors. And right below my measurement tools explanation is the example of the Melnick scale that I will be using. Methods. First, my design is a quality improvement pilot study on prevention of post-operative surgical site infections related to surgical prep will be conducted. Using the Johns Hopkins evidence-based practice model over a 4-month period, this study is a retrospective and prospective analysis of the cardiovascular surgery database surveillance data of cardiovascular surgical patients at a single institution. My subjects for the retrospective chart review, inclusion criteria will consist of reviewing charts of cardiovascular patients that underwent surgery between June of 2015 and 2020, June of 2020. Exclusion criteria is cardiovascular patients that had surgery prior to 2015. Educational intervention and prospective practice assessment. Inclusion criteria will consist of surgical nurses that have a primary assignment of cardiac or vascular surgery that consent to be a part of this study. They will be registered nurses, work primarily in the operating room, and work with vascular or cardiac teams. Exclusion criteria: the nurses are not registered RNs, they do not primarily work in the OR, and they are not members of the cardiac or vascular teams. The setting is a Level 1 trauma medical center in rural New England with surgical patients undergoing cardiothoracic and vascular surgery. The data from the offices of cardiothoracic and vascular surgery will be used for follow-up appointments with patients 45 days post-operatively to determine if an infection occurred. Informed consent and expedient review is appropriate as there is minimal risk to participants and surgical members of the teams, and the board is already on board with the change in policy at UVM. The nurses consented to being part of the study by signing a written informed consent prior to the start of the study. The informed consent included the explanation of the study's purpose, inclusion and exclusion criteria, what was expected of each participant during the study, risks, benefits, and rights of the nurses to voluntarily enter, refuse to enter, or leave the study without penalty. The informed consent was also explained that no compensation is connected to the study in any way, and the contact information of the researcher and the IRB was represented. My process is listed below. First, an expedited IRB will be performed for Regis College and UVM Medical Center. Recruitment of surgical nurses that care for cardiac and vascular patients will be recruited for the pre-assessment and educational intervention. The informed consent will be given to the nurses recruited. A pre-knowledge assessment consisting of 20 22 questions of the consenting nurses will be given and completed and returned to the researcher. Nurses will attend an educational session explaining the manufacturer recommended process for antiseptically prepping a surgical patient, and then engage in a surgical assignment as typically assigned during their work time. The participant responsible for surgical skin preparation of the patient will fill out a 22-question post-assessment. This questionnaire will be collected by the researcher or dropped in a box at internal control and then be entered into the post-intervention adherence worksheet. 45 days post-operatively, the researcher will access the patient's medical record to record the presence or absence of infection. The retrospective chart review data will be entered into the post-intervention infection or no infection worksheet 45 days post-operatively, and the researcher will access the patient's medical records to record the presence or absence of infection. Data will be entered in the post-intervention infection or no infection worksheet. The Melnick EBPI scale will be used to measure adherence among the nurses. My theoretical foundation below is a picture of the theoretical foundation I am using. It explains the Lewin's theory of change, which results from the analysis of causal relationships between status quo and the social environment that governs behaviors. Lewin's change theory creates change initiatives to destabilize the status quo, implement the alternative, and restabilize the environment, a group process of trial and error until an appropriate fit is found. It is a process of engaging, establishing the working relationship, focusing, developing a direction, evoking, activating motivation, and planning, creating a change plan. Rejecting prior knowledge and replacing it with new information is the first stage of Lewin's change theory of unfreezing, which is the process of finding a method to guide individuals in abandoning old processes of behavior and resolving resistance and group conformity to change. The second stage of change theory, moving or changing, is the most difficult, related to group fear of change. Moving requires leaders to persuade individuals that the status quo is detrimental and not beneficial, then change their perspectives and behaviors while personally and cooperatively connecting with other supportive leaders. Creating a new equilibrium, the third and final stage of Lewin's change theory, refreezing, involves establishing the identified change as a new accepted and supported habit. For this scholarly project, the first stage of unfreezing involves acknowledging that the nurses in the cardiovascular and cardiothoracic surgical units potentially will be resistant to changing the antiseptic agent and process of application that is currently used. This stage addresses that this change in protocol may increase time spent on application by the nurse, and even interpreted as an insult, punishment, or reprimand by nurses at different stages of their career. The second stage of moving involves trial and error with the prospective antiseptic agents and determining which agent best prevents post-surgical wound infections. The final refreezing stage allows surgical nurses to continue the application and process of the most effective evidence-based antiseptic agent chosen that proved to decrease sternal wound infections post-operatively in patients. An accepted, adopted, and supported change in policy is one example how Lewin's refreezing change processes. My retrospective data collection. First, I will use a demographic data worksheet to collect pre- and post-intervention chart information amongst cardiovascular patients from June 2012 to June of 2015, and June 2018 up to June of 2020 for cardiac patients. Vascular first changed to universally using solely ChloraPrep in 2015, and the cardiac team first universally switched to using only ChloraPrep in 2020. Understanding and collecting this information will allow me to understand and support that the patient did not acquire an infection and return to baseline health after their surgical procedure. The educational session, to your bottom of the right-hand section of this educational session section, you will see my flyer that I'm handing out. It will be performed after the pre-knowledge assessment. It'll last 30 minutes. We'll include this educational flyer and we'll go over procedure for prepping, maintaining sterility, drying times, and dealing with contamination. The data analysis for the retrospective chart, measures of central tendency will be used comparing prep use and resulting postoperative infection at 45 days will be measured for the categories. The categories consist of age, gender, month, surgeon, specialty, surgery received, readmission, reoperation, BMI, postoperative infection 45 days, prep use, and comorbidities. The pretest will ask 22 questions and show the mean number of questions answered correctly by nurses, the median between nurses that understand protocol and require more knowledge, and standard deviation from knowledgeable and complacent nurses. The post-test will aim to show the increase in knowledge acquired and adhered to by the nurses related to the mean number of questions answered correctly and lack of deviation in the trend of answers. Prospective, this will be collected into a post-operative table. Frequency and percentages will be used, and measures of central tendency for the 2-ratio item prep used and post-operative infection at 45 days will be measured for the categories. Finally, I will compare the post-intervention adherence questionnaire means of correct responses to prospective chart review percentages of infection in patients after their 45-day follow-up. This will perhaps show how the adherence or lack of adherence in nurses affect the resulting infections or lack of infections in patients. The potential benefits of this project are standardizing care, which ensures excellent patient outcomes, universally accepting policies that will set forth a benchmark of progress for outlying establishments. Surgical antiseptic prep agents are at the front line of preventing postoperative wound infections, so we can decrease wound infections at the first stage of what can be changed, and prevention of wound infections to reduce rehospitalization, readmissions, the cost of healthcare, and cost of benefits for the hospital. Conclusion: per research that I have conducted, ChloroPrep is the agent of choice in presenting a gold standard of care for preventing postoperative surgical site infections in cardiothoracic and cardiovascular surgical patients. Decreasing infections is a topic of choice currently, and change of practice among surgical nurses is necessary. Thank you for listening to my presentation, and I hope you enjoyed preventing postoperative surgical site infections through standardization of preoperative surgical skin preparation, a pilot study.